All, welcome to a very important session of 3-day APAC HealthTech Innovation Conclave. This session is very important because in this session, you can see the presence of healthcare leaders who will be talking about reimagining the patient care delivery and workflows, especially in the new world order. Speakers who are present here, they doesn't need any introduction because they're all leaders in their own sphere. But I have to do this customary introduction for all of them. So let me first welcome Dr. Alok Roy, Chairman and Managing Director, Medica Superspecialty Hospital. Thank you so much, Dr. Alok, for joining us. We're also joined by Dr. Hari Prasad, President, Hospital Division, National Hospitals Enterprise Limited. We welcome Dr. Hari Prasad. Thanks for joining us. We're joined by Mr. Rupak Barua, Group CEO, AMRI Hospitals. Thank you so much, Mr. Barua, for joining us. We're joined by Dr. Shuchin Bajaj, Founder Director, Ujala Cygnus Healthcare Services. Thank you so much, Dr. Shuchin, for joining us. And we're also joined by Colonel Dr. Sunil Kumar Rao, CEO, GCS Medical College Hospital Research Center. Thank you so much, Dr. Rao, for joining us. Let me inform all of you and also speakers that in this session, we'll be focusing on 3 core points. One is it is time to realign our approach towards patient care delivery, new ways of engaging for a better experience for patients, sharing best practices of patient care, learning from others, and what can be learning for others as well. So with this, I'd like to ask Dr. Alok Roy, Chairman and Managing Director, Medica Superspecialty Hospital. Do you think, Dr. Alok, that this is the time that we all should realign our approach towards patient care delivery in a different way? What's your take on that?
Thank you. Mr. Goswami, thanks for inviting us to be here with you and share our thoughts. Time to realign our approach towards patient care delivery. I think we got a wonderful opportunity, though it was at a wrong time. But in last 10 years, the doctors have gone through a very tough time as far as the media and their reputation is concerned in the market. And if some of you can remember, it's a faith quote, "Mein khooni lutere type." This pandemic has shown it's like a samudra manthan where we churn, the entire world got churned, and the people who were really at the forefront defending the world as a frontliner were doctors. It was shown that how selflessly they worked in last 1 year, how without bothering for their lives, for their family. There are innumerable stories where mothers have not seen their children who are 3-year-old. A lot of doctors slept in the car boot because they had senior parents at home. A lot of doctors could not go home at all for 6 months. And some of them were working for 6 days in isolation, quarantine. But they continued fighting, and the results are in front of everybody. This opportunity doesn't come every day. And this opportunity also gives a lot of messages that the same world, especially around our where we are in India, same world is criticizing you, bajao ghanta ghadiyal for you, the conch shells for you, and they beat in the thali for you. That means that there is a value which is very inherent in whatever we do. That value which is inherent in whatever we do has been realized, and time has come to further consolidate and ensure that we walk in the path of patient care delivery, which is as accepted or expected from the society, which we are now in the current scenario is happening. And a lot of understanding also has dawned in the mind of people that a lot of diseases come and take you away. And the people who save you do it not for their reasons, they do it for your reasons. If you lose somebody, in pandemic we have seen that people have lost their near and dear one, and none of them came out and criticized doctors. There was initial some reactions because people are very confused. But once the reality dawned on them, there has been acceptance of the disease. I think it's a very right time where all leaders in healthcare must put put their best foot forward and tell the world that we are here, and build an image, build a care system which is moved away from individual hospitals to community-based services. We can work collectively. A lot of us can work collectively, and we need to be very careful internally within ourselves to ensure that we only put the best practices, whatever is required, forward. And also, what we have learned in last 1 year, that communication is the key. So God has given us an opportunity. We must utilize it and ensure that we deliver patient care by utilizing this learning, whatever we have learned in last 1 year, and take it forward. Thank you.
Thank you so much, Dr. Alok Roy. I think you have set the context for this session by uh, highlighting very important part of this panel discussion. Dr. Hari Prasad, your take on this?
I am actually reminded by the Great Berlin Wall, which used to separate the then East and Western Germany. And all of a sudden it came down, and the borders were no more there. The communist and the democratic part became one. Not that I'm vouching for one of them, but they became one. So it became a borderless place. And disease COVID has now shown that
I
there
think
is no.
some noise is coming. If I can make request, a phone is coming. You can switch off that phone.
Yep. So COVID has proven that it is a borderless world. It's a connected world, and born in one corner of the world somewhere, it is actually impacted the entire world. So one thing which I would say is the world has become connected, and I would also say that the future is going to be realignment, and the realignment of healthcare and reimagining healthcare would revolve around a connected patient. Now, we are beginning to see, or we have already seen, a lot of patients staying at home and still getting healthcare, whether you call it telemedicine, teleconsult, whatever may be the technology. You're already seeing that happen. I think going into the future, beds will become irrelevant. I can't really be proud that I'm responsible for 10,000 beds, or Dr. Alok cannot say that he's got so many thousand beds, because beds are really going to become irrelevant. And I've seen in my own career that the average length of stay of a patient has come down from 10 to 5 to 4 to now 1. We are doing daycare knee replacement surgeries. We are doing overnight minimally invasive cardiac surgeries. So more and more care is going to happen outside the hospitals, minimal hospital stays. And what this model of care demands is the patient to be connected. Whether it is in an outpatient setting, whether it is a patient who's had surgery and in the post-operative setting where he used to be in the hospital in the past, today is going to remain at home and be monitored and care be provided at home. Or whether it's an acute setting within the hospital. Today we have the geographic boundary of an intensive care unit and really sick patients being taken care of in the intensive care units. Imagine a situation tomorrow where all the rooms in the hospital are connected and a sick patient can be taken care of in any room because all the rooms are connected and every room is an intensive care unit. So that is the sort of impact this connectivity is going to happen. And we are really looking at a patient who is connected to change the patient flow and realign the way healthcare providers start building out hospitals, realign the manner in which, reimagine the manner in which they reach out to the patients and keep the connectivity of the patients on. So I really believe that COVID has taught us a lot of lessons. Some of them will disappear, and that is for the good. But some of them will stay back and will revolutionize the way we deliver healthcare. And I think that's going to be the beginning of a new way of delivering healthcare, and it will impact everybody. It will impact the patient because his expectations are going to be different in the new connected world. It'll impact the care provider, the doctors and the nurses, because the way they deliver care is going to be different. It's going to impact the providers, the hospitals, because the way they build out the hospitals and the infrastructure they provide within the hospitals is going to be different. So I really believe that we will need to reimagine care for the future, taking into consideration all the new models of care that have evolved during this period, consolidate them into one thing, and start providing for a connected patient. And I think that is how we are reimagining the new care, new sort of healthcare in this era. Thank you.
Yeah. So I'll come back to Dr. Hari Prasad with more on this. Let's have a perspective from Mr. Rupak Barua, Group CEO, AMRI Hospitals, Kolkata. Mr. Barua, your thoughts on that?
Thank you, Souvik, for discussing such an important issue in today's healthcare delivery system, ecosystem, actually. Now, yes, of course, all my previous speakers were spoken about the importance of this your realignment of this your healthcare delivery system and the patient engagement. It has become a very important kind of a subject for discussion and to take it forward. Now, during this COVID situation, actually, which we had navigated through a very, very bad time, hard time, challenging time, and particularly for all. And we could see how the patients are helpless in this situation and what are their expectations. See, patient engagement or the patient support, we are all talking about many days, how best way possible we can engage the patient, more engage the patients. But now we have reached a situation where how we can create a holistic patient engagement capability. That is one part, supported by enabling technologies that we need to keep it in mind, secure data, that is also very important, and a unique experience personalized to meet each patient's need. Now the question is, there is a lot of different kind of patients, different kind of a need. Now we need to see which patient is looking for what and how we can handhold them. Now it's here actually playing a major role, that post-COVID situation that we could see, that is enabling the technology. Technology is playing a major role where in terms of delivering smart healthcare, technology is playing a major role, where we can use this technology to satisfy one of our patient. Now, there are many ways to introduce technology. Yes, of course, that is a patient comfortability that we need to see. One of the other part that already other previous speakers that mentioned about the communication. One is the major important issue on this your patient delivery is it your how better way possible we can introduce a very, very smart kind of a communication system in the communication in the ecosystem of this your healthcare delivery. That's a very, very important part. The other part also that during our working out in the healthcare sector that we could see the patient as a burden with a lot of financial liability. Here also they are expecting that is because more we have seen in the COVID time when there is a patient is in the critical care or the patient is in ECMO, the cost is going up. So here is actually we need to work out how best way possible we can handle the patient's financial part as well. So these are the three parts. The technology we can help us in many ways, but one part is the communication. Yes, of course, to the patient, patient's communication, patient's relatives communication, so that they are looking for the patient's outcome, clinical outcome. And the other part is the financial part. So financial part, I'm not saying that funding of the financial part, but need to understand there's how best way that we can reduce their cost and can give relief to the patient considering the patient's outcome. That these are the things actually is it's talking about the new realignment which is required in terms of healthcare delivery, and we all need to really religiously we need to work out in these 2 or 3 systems. Thank you, Souvik.
Thank you so much, Mr. Rupak Barua. I'll come to that part, a very important point raised by you, the costing, communication, and technology. We'll discuss that question with all of you, but let's have a perspective from Dr. Shuchin Bajaj, founder director Ujala Cygnus Healthcare Services. Dr. Shuchin, your thoughts on the first part of this panel discussion, that is time to realign our approach towards patient care delivery.
Yes, thank you very much, Souvik, for having us here, and it's wonderful to listen to the luminaries of healthcare here. So, as I think Dr. Hari Prasad said, and as Dr. Barua also said, that healthcare systems worldwide, are unsustainable. Patients get diagnosed at a late stage. The cost of providing modern treatment is rising, and we have an estimated shortage of around 4.3 million health workers. So it is obviously time to change, because for more than 2000 years, I think, since Hippocrates came in, the medical information, medical technology, experience, and knowledge have only been accessible within the so-called ivory towers of medicine that we have created. But nowadays, instead of practicing the art of saving and improving lives, the modern physicians are spending most of their time in tasks which are repetitive, which are amenable to automation, and we can easily save their precious times if we can help them realign their properties. So, in the 21st century, new technologies, social media, smartphones coming in, digital health coming in, everything has changed the status quo, right? Any medical study, information, technology, it is easily within the patient's reach. Patients now want to take an active part in their care. The doctor patient relationship is becoming an equal level collaboration, instead of what it was earlier, with the balance of power firmly in the doctor's side. So now this requires the attention, empathy, and creativity of the doctors even more than ever. Benefits are obviously clear. The collaboration between doctors and patients, powered by disruptive technologies, will shift the focus of healthcare from treatment and sick care to actual healthcare and prevention, making it much more efficient, cheaper, more accessible. Uh, if we can recognize the patient's issues in time, if we can actually predict their illnesses, the unnecessary burden will drop away and the costs will go much lower. So I think we need to shift our focus very quickly to digital health, to robotics, to AI, to 3D printing. We've already started getting FDA approved drugs. The FDA recently approved a epilepsy drug, which has entirely been built on a 3D printer. So I think these issues need to be looked at a lot. There is a lot of change in progress, and I think it will be a very, very rapid change from now, because under the WHO also has committed to a triple billion set of goals, as we know. 1 billion more people to be benefiting from universal health coverage, 1 billion more people to be better protected from health emergencies, and 1 billion more people to be enjoying better health and well-being. And all this can be possible only through digitalization, taking on a new meaning, new dimensions. I think these public health goals can be achieved only if we all partner together in the safe, effective, and affordable application of digital technologies in strengthening health systems and public health capacity. So I think a lot of changes in the offing. Very happy to discuss more as in we go to the panels next.
Sure, sure. We'll come back to you, Dr. Shuchin Bajaj. Let's have a perspective from Colonel Dr. Sunil Kumar Rao, CEO, GCS Medical College Hospital Research Center. Dr. Rao, your perspective.
Yeah, good evening to you, all of you, and my senior colleagues from the healthcare field, and all of them are so experienced. And in this particular format, by the time my number came, I think all the points have been covered. But notwithstanding that, what we felt and what we experienced during this time, COVID times, and subsequently, is what I thought I will share. That what we learned is this: that even a smallest hospital can turn into COVID hospital without much difficulty. Is the first lesson we learned. Another very big lesson which we learned is about the manpower. We are really, as Dr. Shuchin Bajaj said, we are really short of manpower and trained manpower and the manpower required to fight against such pandemics as well as various other aspects. There is a perpetual shortage of trained people, and every time we learned how to do multitasking, how to become lean and thin organization and still survive. And the survival was all of us remember those days when we were struggling and we were saying we will cut your salary and we will do this and we will do that, and ultimately we could manage within the existing resources the entire pandemic very well, and then also could give some incentives to our own people. So my focus today is development of the manpower, which is the most important thing in this whole thing for realigning the patient care. Realigning cannot just happen just like that, though definitely technology is playing a very good role, and we also involved ourselves in all modalities spoken by my previous speakers. For example, remote technology, which was used for doing various pulse oximeter or various other things, parameters which can be done. Home care, somebody spoke about. Yes, we did. All of us went through this home care cycle, and where remote measurement was taken. We took blood samples. We took various other measurements at home. So that realignment is taking place, but the most important element in our setup in healthcare is the manpower. I think we have to pay attention to that manpower element very much. And all of us also remember that the first attack which came in March, April, so many people deserted their fort and went away. And as leaders, we had so much of difficulty to capture those back. I am from army, so deserting is a very big punishable offense, a court martial offense, I would say. So here that is also not possible in private healthcare. So we were struggling. So I would definitely recommend Prime Minister's idea of a bridge course and short-term courses to train maximum manpower. The same manpower came back, but they came back in the peak of the time to look after the patients. Patients definitely would like to have human touch. All of us have experienced this. At the end, when they were inside the ICUs, they wanted to see their near and dear ones, which was not forthcoming. So we used the technology also. We used our WhatsApp. The nurses and the attendants, they used the WhatsApp because many times the mobiles were not allowed because of surface disinfection and things like that. So many fears were there. All of us remember that. We converted our existing small setups into COVID setups and carried on with our duties. Then the same second wave is already there in Maharashtra, Gujarat, and various other states which are facing this. I heard news today from the Karnataka also that it is again picking up. So same problems are coming back. We were the first one to apply again back for getting us the permission for doing COVID care. That because we are so well trained and so much realigned with the healthcare of these patients, so we did not take much time to realign ourselves, and we have again started off with our COVID duties. So essentially, I would like to harp again on the healthcare manpower, which is woefully short, woefully unskilled. Most of my 45% of the nursing workforce is absolutely raw manpower, and we have to retrain them again and again. So retraining is a must to realign. Just like that, the patient care won't improve and cannot get realigned to that extent. We have to learn these lessons. And my previous speakers also brought out the topic of cost-effective care, which we all are experiencing because of Ayushman Bharat. We were made compulsory because of government rulings. That again factor I wanted to bring out, that the patient care realignment is totally dependent today on political forces as well as governmental forces, which keep on changing their ruling every now and then. If it is a BJP ruled state, then you won't face much problems. If it is a Congress ruled state or it is a non-Congress ruled state and some other parties, then again there are so many conflicts which happen and which affect the patient care directly or indirectly, because the policies, really political policies as well as governmental policies, affect day-to-day life in private hospitals also. So these important points I thought I must bring out before the audience to ponder
Indeed,
on.
indeed,
I'm
very
ready to
important.
answer any other questions.
Indeed, very important points you have raised, Dr. Sunil Kumar Ron, and uh, I think we'll also discuss about that. But a very important part which you have mentioned is that the non-availability of skilled manpower, which has been a challenge, and maybe when we are talking about realigning our approach towards patient care delivery in the new world order, whether that will be a challenge or not. But as you rightly said, we can see the surge of second wave in various states of India, but it's quite enlightening, and we're all hopeful. What you have said, that we are ready for the second wave as medical practitioners or healthcare professional, because we have already realigned ourselves once this COVID struck. So I think that's again a positive thought by Dr. Sunil Kumar Rao. We'll come back to that. If I come back to Dr. Alok Roy, Dr. Roy, Mr. Barua has said, Rupak Barua has said that when we're talking about realigning or reimagining our patients' care delivery, talking about new ways of engagement for better experience for patients, technology, communication, costing. Do you think these three aspects need to be now also re-looked at?
Obviously, it is important. Whatever Rupak has said is what is being practiced, and this pandemic has taught us. In last 1 year, we have learned that there was a situation where people were not willing to come to the hospital. So all of us went ballistic and created telemedicine, where and doctors were willing to. So doctor, instead of seeing 20 patients in OPD, he was seeing 30 patients in telemedicine. Especially the medical specialists were awfully busy in seeing patients from distance. That became the new reality. We all did some hundreds of telemedicine in a day, thousands in a month. That was reality which has come down significantly because now the people start coming back to the hospital. So the always the crisis, as I was telling you in the beginning, when the crisis happens, you learn new ways. We also learned that government allowed us to set up a hospital in a hotel where we could park not very sick patients to the new places which government permitted. Government did not come up and asked us that you have this minimum, this number of bed, this number of people. They said as long as you can treat somebody outside the hospital, you can go ahead and treat it. And we realized a lot of our patients, by just parking a doctor and a couple of nurses, we could take care of 50, 60, 70 patients in one go. So these are all were new ways of engaging for a better experience for the patient. Patient also were happy. They were not in a COVID hospital. They were in a COVID hospital, but which is not as sick hospital. So care almost shifted. Now they say the COVID treatment of choice is home. Now the moment you say COVID treatment of choice is home, obviously it's for those patients who are not sick. We know that only 15% of patients who get COVID need hospitalization. The rest 85 can be treated at home. So a new home care module has evolved. A new algorithm has evolved which needs a patient to be seen at home, take his blood test. The family member chip in. They chip in with the oxygenation, they chip in with the fever marking, they chip in with the patient care, especially those who had COVID, they're taking care of it or from a distance. And there are instances where one person got in the family and nobody else got in the family. So obviously they could isolate the patient. So there has been a lot of learning. The referral, doctor's referral. Many doctors who need a referral for a COVID patient, but they didn't want to go in because of obvious reasons, and they went digitally. That is now accepted practice. We have realized that this is a new way of engaging for referral. You don't have to come. Earlier, any doctor, even the smallest of a problem, had to visit the patient physically. Now we have realized that digitally is fully acceptable. When we can do it for last 1 year, why we can't do it? So hospital care has been redefined, but also shown the sharp division between the general care and the ICU care. Now, the ICU care could be very high tech, general care could be low tech, and both can be digitally dependent or driven. And obviously, the manpower engagement in this has been phenomenal. The cost has been very high. Technology has been has played a very important role, but we could not pass on the entire burden of cost to the patient because it was just not feasible. And so we had to, all of us had to support. All of us means all the institutions had to support patient and the relatives. Many times patient did not pay, and most of us were kind enough to let it go because they know that they don't have money. And many times the many family members of the same family got admitted. So obviously the technology cost and these new learnings has brought us forward in a way, in a probably more humane manner. We have realized that all of us can very unexpectedly. I'm sure many people will buy insurance. They've realized how those who were insured were better looked after than those who were not insured. It's the reality of life. If they had to go to the government hospital, we all know that government hospitals have a limitation. It's not that they don't want to deliver good care, but they have a limitation. So they all wanted to come to the private care, which is expensive because it's a self-funded scheme, self-funded institutions. So there has been a lot of learning around us, and hopefully that we will ensure that with these new learnings, we continue pushing our agenda of delivering good quality care. Yes, universal healthcare will come in, but we have to watch it very closely. We are also watching it very closely wherever we are, and it has its own challenges. But I'm sure at the end of the day, the victory will be delivering a quality care irrespective of what patient pays. Thank you.
Very important points. At the end of the day, victory will be of quality healthcare, irrespective of what patient thinks. Dr. Hari Prasad, your take on this particular question on technology, communication, costing. Uh, when we're talking about reimagining patient care delivery and the workflow, your thoughts on that? If you can unmute your mic, please.
As I said earlier, COVID has taught us many lessons, and all of us innovated and brought in a lot of new things because we had to do it. There was no option. And I think we need to now start talking beyond COVID, because I strongly believe that COVID has now become a part of the disease burden of the world. Like we had cancers, like we had heart attacks, and like we had influenzas or tuberculosis. I firmly believe COVID has now become a part of the disease burden. So we would need to definitely look at the lessons we've learned from COVID and extend those lessons to other situations beyond COVID. I'll tell you an interesting story. We had a surgeon who was very good at doing robotic cardiac surgery, and there was a patient who did not want to stay in the hospital for very long. So the surgeon said, I don't need to keep this patient very long in the hospital, but there needs to be a mechanism by which I can remain connected and I can take care of the patient even after I discharge the patient from the hospital. So he did the robotic surgery. Patient went home the next morning, and patient was continuously monitored through our EICU with a nurse at the bedside for the first 3 days. And after that, the family took care of the patient while they were still being monitored from our EICU. So this was a natural extension of what happened during COVID into non-COVID situations. And I think that is the new normal. And what is also happening is, by reducing the length of stay within the hospitals, by adopting new technology, the costs come down. Costs have become a real problem. Everybody seems to be talking about costs, and everybody is genuinely concerned about the costs. Even the hospital providers are concerned about the cost, and it is on many occasions beyond the hospital providers. There's a cost of technology, there's a cost of human resource, there's a cost of material being used. So there are a lot of costs which are involved. So even for the providers to bring down the cost, there have to be solutions, and I think technology is one of the important solutions which can bring down the cost. And we were talking earlier about communication. I think one of the biggest, yesterday somebody was asking me, why is litigation going up in healthcare. The reason litigation is going up in healthcare is the patient expects much more communication from the patient, from the doctors and the care providers. I think one of the undisputed leader for cause of litigation in medical litigation is lack of communication. And I think we would need to pay attention to that, whether it is online care, whether we continue with the physical form of care, irrespective of the form of care that is being provided. I think communication is critical, and that is something which we were not really good as. We have to own up. We were not really good as providers, as doctors, as nurses. That is an opportunity for improvement. And I see that we have, to a significant extent, learned that lesson during the COVID period. And I only hope that the lessons learned will be sustained and will take us into the future and will stand us in a good stead in the future too.
Right, Dr. Hari Prasad. If I come to Mr. Rupak Barua, Mr. Rupak, Dr. Hari Prasad just has said that one of the main important factors for litigation in healthcare comes when we talk about communication. So, do you agree with that, or do you have a different take on this?
Yes, of course, I agree. 100% I agree that this communication is one of the major component in terms of healthcare delivery system. And rightly, Dr. Hari Prasad has mentioned that because today, if we see more number of litigations in terms of healthcare, that is majorly it depends on this your poor communication being taken care by the healthcare. Now, when we all talk about that, there is one of the major issue as well. We are all discussing about the cost cost and the quality part of the healthcare in healthcare. Now, you see, one thing we need to understand: this is not is our issue. Regardless of country or culture, you will find the cost of healthcare have a tendency to rise. There is no doubt of it. And it's rising faster than overall cost. That means, if you talk about the healthcare comes in an ever-increasing share of GDP. The healthcare, if you see all our past history, if you can see, always healthcare consumes the maximum amount of our GDP, and it is so. If in talking about this your healthcare delivery system, cost is of course the part of the cost. And also there is one part is coming as well, the quality. Now, quality is one part is cost you can measure, but quality you can't measure. There is no 1 meter, 2 meter of quality. So quality is absolutely a subjective part. My hospital quality to other quality care is absolutely subjective. I can claim I am the best quality hospital. Everybody says best quality or world's best hospital. We are always talking about the best quality healthcare, suppose giving, but ultimately, end of the day, we are not. With the patients are not satisfied with my quality, with my service. Now you see, this is so healthcare. If we can see, this is if we can really can look into that, healthcare is not only as a cost problem or a quality problem. If we cannot, but that the key indicator should be that the patient outcome per cost incurred. That is so whatever it's called actually value for money, and it is called value agenda as well. See, one thing you need to understand that more treatment, more expensive treatment, it doesn't mean that you will get the quality, best quality. So you will have to understand, because the more part we have talked about that in this pandemic time, what we have understood that is the cost part that we talked about, because more of the patients were in the critical care and all. So if we look into this, the future part, that we'll have to balance between quality and the cost. Nobody will say that you reduce the cost at the cost of the quality. But again, we'll have to see whatever your quality you are delivering, that is a cost you should balance. So that is the major part that we'll have to work out. This is the new initiative or the new agenda in terms of your patient care. And that has to be properly communicated to the patient. So whatever you are spending, the patient, they are spending, each and every process, you will have to let them know that this is the process. We are doing it for your better outcome. And if you can really can convince the patient, nobody will mind to pay you, but at the same time, the maximum amount of patient satisfaction you will enjoy. And that is the new normal situation. Thank you.
Thank you, Mr. Rupak. I'll come back to you and to other speakers as well. Dr. Shuchin, your take on this part, this aspect that technology, communication, and cost. We have to realign ourselves in all these three aspects.
Yeah, just to add to the fact about the increasing litigation as well, and is it just due to costs or is it just due to the lack of communication? What I feel is that it is also got to do a lot with the fee for service model that some of the economies follow, right? So, compared to the litigation that is in the US, you would see that the litigation in Europe is not even a fraction of that. Is it that doctors commit less mistakes in Europe? I don't think so. I think the main factor there is the trust is built into the entire ecosystem because there is no fee for service there. So a patient will assume a mistake instead of assuming malice if there is no fee for service. Like in India, there is usually a fee for service model. So if there is any mistake from the doctor, the patient assumes that the doctor did the error as a malicious act to earn more money. They did the surgery unnecessarily. They just want to earn money. Like Dr. Alok Roy said in the beginning that it was a looter's image that had been created just because I think the incentives of the patient and the doctors are completely misaligned once there is a fee for service model. In a fee for service model, the incentive of the doctor is that you fall sick and you come to me and I will put a stent into your arteries and I will earn the money. On the other hand, the incentive of the patient is not to have that heart attack at all, right? He wants to be healthy all the time. So if he feels that the stent has been put in just to earn money, that creates a sort of a suspicion in their mind, a mistrust, and that is what leads to all these cases of violence and litigation coming in a lot. So we need to rework that, I think, going to the basics, but I think that is an ideal scenario which will take a lot of time. But in the meantime, we need to work a lot more on the communication part, on making sure that the patients understand what is going on. They have their regular in touch. The doctors are too busy maybe to be in touch, but if they could depute a person to make sure that there is always a sort of communication, and if you could automate that process where you get the entire case sheets, summaries, all updates automatically, I think that would create a lot of trust in the patient's attendants and relatives compared to what it is right now, because most of the communication is opaque. You don't really get to understand or listen or meet the doctor for days on together. If your patient is in the ICU, you don't even get to see the patient, let alone talk to them. So that creates a lot of mistrust, and that is where all these folklore stories come in, that the patient had already died 3 days ago, but they kept him on ventilator just to make money, just to build up the bill. These kinds of stories would not be there if we can strengthen the communication network through automation and technology, and make sure that it's not just the doctors and the medical staff who are connected with the patient always, but also their relatives and family members.
Interesting. Dr. Rao, your take on that.
Yeah, again, a lot of people have spoken on communication and technology and various things. So I would briefly say that for hospitals like us, which are charitable and those who are surviving on Ayushman Bharat, so to say, has to perforce use technology in terms of estimates in communication. Definitely, biggest factor nowadays is the trust between hospital and the patients, which has come up as a big factor, and the mistrust is always there. So, fortunately for us, everything is defined as packages or various types of cycles, especially when I'm dealing with cancer hospital. So what happens is the technology definitely is there, but technology is packaged into various scheme patients done by Ayushman Bharat, and various categories have been defined, various diagnoses have been defined to package these things. So that definitely use of technology has helped us. Everything is taken. The photograph of the patient is taken, the card is taken, the Aadhaar card is taken, then various documents which come, radiotherapy records and what have you. I mean, everything has to be uploaded. Then only you get the money. Rather, everything is so well documented that immediate query is also raised. Similarly, from patient side, if there is anything which goes wrong, immediately it goes on to the Prime Minister's portal. So PM portal has been opened and the communication goes directly onto the PM portal, and you have to reply within 24 hours. If you do not reply, again, there are penalties of different types. All those things are there. But one big factor which I wanted to bring out here, especially for patients which were non-COVID, especially our cancer patients, almost 50% dropout rate was there. Though we tried a lot of other technological aspects like keeping in touch with the patients through WhatsApp and communication modules of various types. All these M-Fine and all those platforms also be used, but still the rate of dropout during this pandemic was almost 50%. And those who are now suffering the advanced stages, and the mortality has increased proportionately in the cancer patients specifically. And cancer, as you know, is heavily technology based, especially the radiotherapy portion of it, which can't be done remotely in any case, whatever you may try. So certain things are beyond technology also. Just wanted to bring out this aspect also. Definitely, we used the patient care coordinators specifically to call up each and every patient, follow up. Post discharge also we found a new module. Nowadays people are also calling a new methodology which is very popular in the West, for which definite platforms have come. Is called PROM, patient reported outcome measures, which is being used prominently to improve the patient outcomes, and as reported by them, not reported by the doctor or by the healthcare workers. It is purely their aspect, their feeling of how they look at patient, their outcomes in terms of cancer care, or in terms of various other cares like joint replacement and their mobility, and how they are able to move in, are they able to do their daily tasks, and how many days after their operation, etc. So these things are also becoming important, and they are also technology based. So the platforms have been created, the software has been created to report on this, and periodically the patient care coordinators get in touch with the patients, operated patients, as well as the cancer patients, to know these outcomes. So this is another portion of technology and communication and the patient engagement, which your topic is also of today, about patient engagement, various methodologies. Thank you. So I thought I will bring out this topic.
Very important and pertinent point raised by Dr. Sunil Kumar Rao. If we can come, we can just take one more or two more questions for each of the panelists. My question is that we are talking about reimagining our patient care delivery. So we have seen the first 1 year of COVID, the pandemic, and how hospitals have responded to that. Now we are again seeing a spike in COVID cases in various states, and that's everybody, most of the important stakeholders saying it's almost a second wave in India. So are our hospital ecosystem, I'm not talking about only about the government hospital ecosystem or private hospitals, are our healthcare infrastructure is well equipped now or ready to face this kind of pandemic again, and especially keeping in mind the mental state of the patient, and when it comes to patient care delivery, can technology be the game changer, or it has been the game changer, or there has to be a touch of human touch along with tech touch? Your take on that, Dr. Alok Roy. If you can unmute your mic, please.
Sorry. Second wave is reality. We are seeing that Mumbai and Maharashtra has the highest number of cases, as much as they had in the pandemic, and which is worrisome. A lot of states have gone on lockdown and night curfews, and they've shut down their theaters and picture halls and all that. And but having said that, we have gone through a very, very bad phase. And the country was not prepared that time, and we tackled with it. So I don't see any reason why we can't deal with it. And we can deal with it, and we are better equipped. We are better equipped in terms of equipment, in terms of medicines, in terms of patient education, in terms of the biggest and foremost thing in our hand is vaccination. I think every media must promote that more and more people must be vaccinated. We must tell government that don't bother about 45, 55, 55. Give inoculation to as many people as possible. More private hospitals should come forward and vaccinate, because that's the only way of preventing, slowing down the second wave. And we have learned the art of that the only thing which saves for sure is the masking, sanitization, and distancing. Let's not forget that. So if we have put all those practices in place, I think country is more than ready in terms of equipment, in terms of medicines, in terms of everything. So I don't see Mr. Bhami, why can't we, Mr. Goswami, why can't we deal with it? We have dealt with it earlier, we'll deal with it now. But I would also like to address one more thing at this point of time, which you said in the beginning, and which we all have been, all speakers have touched that point, is that realign our approach towards patient care delivery. When we said that when the pandemic happened, and as I mentioned the Samudra Manthan, when I said that we had the opportunity where a lot of churning was happening, and we came forward and helped people selflessly. And that has put us in a very right frame of mind, in the mind of people who are taking treatment from us. But that does not mean that those troublemongers have gone away. I just want to bring one distinction here, that all the big hospitals, institutions have a control. No individual can be a rogue for a long time. It can be caught. But there's very little control over in a smaller town where the lot of not so good practices happen. And that becomes a news, and that becomes a reflection on all of us, which is not true. So the majority of the institutions in this country practice as the medicine is practiced anywhere in the world. They don't deviate. They have the same system, they have same ethos, same process. Like Dr. Rao was saying that he is the Ayushman Bharat, you can't do anything. Everything's so watertight. But even then, there is so much of fraud. People had a fracture repaired, and when they went to see him, he was roaming around a scooter in Uttaranchal. We all know it. Many such cases happened. The fraud happened there also. So what we need to do is that identify such people, go for self-audit, go for transparency. And whenever we have such opportunity, the leaders in the country in healthcare must get together and kind of put embargo on such activities. And then probably media will be more responsive, they'll carry more positive stories, and we'll continue to be healer and continue to be respected as we were getting it just a decade back. Thank you very much.
Thank you so much, Dr. Alok Roy. Dr. Hari Prasad, your take on that. If you can unmute your mic, please.
I don't think that question should ever arise. As Alok said, we dealt with it when we were not prepared. So now that we've gone through the whole cycle, I don't think there is any issue in handling any further spikes of the pandemic. But as I said earlier, I strongly believe that we should take it as a part of the disease burden of the country. We should no more look at it as a COVID and non-COVID. We should take it as a disease burden of the country. And there are going to be instances like dengue. You take dengue, and dengue, we had a seasonal period where dengue the numbers used to go up, and then they used to come down after that season was over. So we need to look at the spikes in COVID also in similar fashion. But obviously, we would need to be extra careful and make sure that the acute form of the disease is minimized, because we are not yet there in terms of being able to provide curative care for these patients. And what we are also seeing is a lot of after effects of the COVID patients. for patients who become really sick, it does not end with the discharge of the patient. We have seen patients who needed lung transplant after recovering from the COVID infection. We're seeing strokes, we are seeing MIs, we're seeing multiple other diseases after coming up after COVID. So it is not only COVID becoming a part of the disease profile of the country, COVID is actually adding to the disease burden in the country with the so-called non-communicable diseases. So I think it is going to be a double whammy, but still I imagine that we are better prepared today than when we were at the beginning of the pandemic. Now, there's another aspect which you were talking about the physical versus the digital care. I always believe it's going to be a combination of the two. The touch can never go away. The touch is always and always going to remain there, and it's going to form a very important part of care. While technology can supplement, can increase the efficiency of the touch, and can actually reduce the points or reduce the need for more manpower, or substitute for, or create a solution for lack of manpower. But touch is always going to be there, and it's always going to be a combination of a touch with technology, and the technology piece is going to be enhanced in the future, but the touch is never going to go away.
Touch is never going to go away. I remember in the inaugural of this conclave, one speaker talked about that the future lies in the human machine partnership. As he was exactly saying what Dr. Hari Prasad was saying. Mr. Rupak Barua, your take on that?
Yes, Souvik, this is so far you were all talking about that if the way this year COVID again there is an increased number of cases, how we are well equipped to handle the situation, the pandemic situation, what we had faced last year. See, two ways, if you are talking about the suffering part, yes, two ways we had suffered. One, we had suffered as an operational part, that how to manage the patient as a COVID patient, and the tremendously private healthcare actually had suffered in terms of your financial part. That is almost the occupancy came down to 35%. And if you see this year operating losses, I'm talking about cumulative as in healthcare, considering this year almost is your 2.4 lakhs crore is the private healthcare as a whole turnover. And there is a 13,400 or 14,000 around is the operating loss has been estimated during the first quarter, considering 35% occupancy. So that is a tremendous amount of financial losses the private healthcare could see. Now, over the time, yes, of course, there's a lot of trouble we had faced, but over the time we had learned a lot. We had learned the first part that we had learned how to manage the COVID patients. That is one part that we can see. And the other part also, the clinical part, is of course clinical part. There is a lot of new medicines has been introduced, new protocols, and we could see how best way possible we can handle the patients and can reduce the average length of stay of the patient. Initially the 14 days as per the government protocol, and then gradually we could see there is a 4-5 days. And there's a lot of other aspect, that is a home healthcare, then your satellite center, so many things we could understand. But again, we are saying that is yes, of course, in a quality way, in the operating way, yes, we have not understood. But one thing we need to see, this is we have tremendous amount of infrastructural deficiency. We do not have sufficient number of beds considering the population. So one has to be very careful. It is, and the complacency part that we need to rule out. And as Dr. Alok was mentioning, that is a vaccination part, that is a very extreme way that we need to continue. The other part is, over the time, digitizations of the healthcare system has been taken place many ways, and is in this kind of a pandemic situation or in the COVID situation, this is a major part that that digital part that we need to continue. At the extreme level, we need to take care. And whatever the physical part is, of course, it will be there. You cannot just rule out the physical touch. It has to be there. But digitizations of the healthcare that we need to do very, very religiously, aggressively, so that in each and every touch point where the patients are looking for support of the healthcare, this digital part, digitizations part, or the technology can take place, and that can reduce further amount of your spread of the disease, and better way will be able to handle the patient. Right. Thank you, Souvik.
Thanks, Mr. Rupak. Dr. Shuchin Bajaj, your thoughts on that?
Right. So, see, I totally agree on all the points, but just a bit of a caveat on that. I think that we need to understand that technology is not really the solution in itself, right? The individual trends in technology that we have been speaking of, all of us, will not have an impact on patients' lives if the role of the entire ecosystem and the major players in the ecosystem does not change. Because technology, as I said, itself will not be the solution. No wearable health tracker or medical robot or AI can make us live healthier lives, right? We can change our lifestyle with the help from useful technologies. So automation is the assistance that we desperately need, both on the doctor and the patient side. But we need to make sure that we create a healthcare ecosystem in which, one, we utilize the brain power of physicians instead of pushing them towards repetitive tasks. We train our physicians to use digital health technologies in a way that human touch and making hard decisions remains the core part of their job. With automation, they can prevent, predict, and treat diseases like never before. And their main focus should be on the human touch part of it, which sadly seems to be getting lost more and more with the bulk load on the physicians that is coming in. Second, we need to empower patients to take proactive care of their health and their own disease. Like the wonderful example that Dr. Hari Prasad gave on how the patient, after a robotic surgery, went home the very next day and then was monitored with the help of a nurse from his own house, and then the entire family took over the caregiving process after 3 days and managed the patient's complete recovery journey. So we need to empower the patients to take proactive care through technology. This is a momentum that is being built up as we listen to that story. But with the swarm of digital health trackers and solutions coming in, I think it's only going to get easier for the doctors and patients to be in touch and allow the patients to take care of their own disease much more. And third, also, we need to allow startups developing innovative technologies to go through regulation quickly. Otherwise, patients will find their own way in the jungle of healthcare solutions if we keep getting the startups stuck in bureaucratic red tape, and the government does not believe in the innovation in healthcare and wants to empower patients. Then it will be very difficult for us to implement all these changes that we have been talking about. The human touch should be the essence of healthcare, and that is when the patients and caregivers can finally pay attention to each other.
Human touch is very important, and technology can be playing the role of complementing the human touch for patient care delivery. Colonel Dr. Sunil Kumar Rao, your take on that? Quickly, 2 minutes to you.
Yeah, I won't take much time because most of the points I think have been covered. But I would definitely say that yes, we are prepared totally. We have made standardized modules for treatment, whether it is about COVID or non-COVID, differentiation, triaging, screening, CT scan, all have now been set very well in terms of technology also. And the standardized module allow the doctors or the physicians to examine the patients within no time. So the patients, even if they are coming in hordes, like hundreds of patients which used to come in September and October, August, September last year, this is the same trend also is possible to be attained with the help of standardized modules and standardized, as somebody had pointed out, in terms of disease pattern also is changing, as Dr. Hari Prasad also said, that newer and newer things we are able to see. But the power of detection of those things has come in. And that is what is our preparation now, that we are able to detect them very, very fast, because we have developed that eye to detect these things very fast, whether it is our cancer patients, whether it is immunocompromised patients of all types, and what could be there. Like, for example, this country or this world has seen so many fungal infections which we never had seen. So such type of newer and newer things are coming up. So sale of antifungal definitely has increased. There is no doubt about it. But because of the use of the steroids, fungus started growing, and now it has become like a common cell, and it attacks as and when required. Almost all cases who are in the ICU are getting fungal diseases. So many new changes we are able to detect because of our preparation earlier, and now we are very well prepared for any kind of pandemic, any kind of disease load which is going to come onto us. So with that, I think I will close my views.
Thank you so much, Dr. Sunil Rao. I think if I take the crux of this discussion of last 1.5 hours or so, that India is well prepared. India means the healthcare infrastructure is well prepared for the so-called second wave of COVID. We have to consider or this pandemic as the disease burden, like any other disease burden for this country. We have to realign our approach for patient care delivery, which has already been done in last 1 year during the lockdown and during the pandemic. And there has to be a complementing role of human touch and technology together. And this is how we are going to reimagine the patient care delivery and the workflow in the new world order. With this, I would like to thank Dr. Alok Roy, Chairman and Managing Director, Medica Superspecialty Hospital, Dr. Hari Prasad, President, Hospital Division, Apollo Hospitals, Rupak Barua, Group CEO, AMRI Hospitals, Dr. Shuchin Bajaj, Founder Director, Ujala Cygnus Healthcare Services, and Colonel Dr. Sunil Kumar Rao, CEO, GCS Medical College Hospital Research Center, for joining us in a very important panel discussion on reimagining patient care delivery and workflows in New World Order on the first day of APAC HealthTech Innovation Conclave. And I'm sure the deliberations made in this session will be of utmost importance for all our audience, all the stakeholders, and we'll be documenting the outcome of this entire event, and we'll be circling to you, also to all the stakeholders of healthcare fraternity in India. Thank you so much. Do join us in our next endeavor as well. We'll now